So what we have decided, because their salary is almost close to some of the nursing posts, that maybe those posts we should repurpose them and try to get the general nurses. Go to the next. So what have we done? We have used agents in nursing, and we have a WhatsApp with matrons and the matron on duty on every day. So if they need a nurse, whether it's 1 a.m. or whatever, they put the WhatsApp. If we don't respond, they call so that we can assist them to get the nurses, because we have actually open beds, a ward at us to screen the patients that come in, because we still run the hospital. The hospital is probably at about 60%, the other wards besides the COVID wards. And our clinics, we are only starting now to reduce them a little bit because our staff is a bit tired. So we are saying those who can get a script and delay to come here, they will be delayed, but those who have to come, we still have to run those 52 clinics in the hospital. What we have also done is that the overtime, province also gave us approval to increase the overtime that the nurses are doing, and those who are able to, we also put them on overtime as and when there's a need. But we have also extended the community service nurses, all of them are on duty, and we have extended them to the 31st of March. Thank you very much, MEC. She really assisted us with the HOD to bring them back. We had also one of the things, as you saw, Minister, many of the patients need oxygen. And so it's sort of high care, critical care. So we thank Mrs. Chitereke, our nursing clinical directorate, together with the head of critical care. They ran a 5-day training course for critical care on the job, and that has helped us, and is a legacy that will remain beyond this. To date, we have trained 266 from our own hospital, but we did 20 for the cluster, and it was a train the trainer, so that when they have their own patients there, they are able to manage. But we have also trained 4 from Mpumalanga province. In fact, they want to have an MOU with us so that we can continue training their staff on critical care as a norm going forward. What else have we done? We had a very good plan as a cluster for elective surgery. Oh, my battery's low. Do you have? Yes, you have to get the charger somewhere. Aslindi, yeah. We had a good elective surgery list, which we had already started. So now we have deferred some of those as a cluster. We put some hubs where we were saying cataract will be done at, let's say, Polotram. So we have packed that, and that staff that was doing elective surgery in theatre, as you can see, we have combined some of the theatres so that the staff from there, including the operators, could be moved to the right place where they are needed. All categories of staff, for example, the speech therapist assists with screening in the morning. In the morning when it's busy, the quality manager is at the door. He just sends a message and all of us go. If it means even us, we have to go and screen because the queue are long. We do that. Go to the next. And we have the psychosocial support. I won't go through this, but just go to the next slide. This is an area that was renovated by Old Mutual, which our staff use all the time, where they have virtual psychosocial support, but we also have them just sitting to chill because it's quite tough in the wards. So they are able to go out and go and have a better place where they can at least relax. We ran a wellness clinic. The need was so big that we are running it 24 hours now. And it's run by 20 staff, as you can see, the OHS and the doctors, the social workers. Go to the next one. And as you can see, during the first round of the peak up to November, we had 944 staff. And we tried to look at from December when the second surge started. As you can see, currently we have got 15 who are in isolation. We've just had 1 death. And we had 85 since the December up to date. But the first round, it was 944. Next. Just the contracts, as I mentioned, some people are not keen on taking the contracts up till March. And one of the things, Minister, I would recommend is that if we extend the contracts, remember after COVID, we still have to deal with that backlog of elective surgery. It will go a long way in terms of really trying to leave a legacy, but also catch up on other things that are a problem. The staff burnout. We have tried to give people leave. As you can see, sometimes if they are tired, they go and rest. Sometimes we do give them off when it's not busy, just so that they can catch up. But we have our own clinicians, the occupational therapists, the psychiatrists. They actually run a program for them to assist them, together with the cluster where we have a virtual meeting. They consult with them. They help them to get through the problems that they have. And the increase in staff is also worrying. But we have occupational health who go around the offices just to check that people are complying, and they try to also do social distancing in the tea rooms so that people do not congregate. And all those things that I've spoken about. Go to the last. These are achievements. We really have a very vibrant cluster. Everybody knows everybody, and we assist each other. We have standardized our protocols. We have bought them equipment. I think on Monday yesterday, we gave them the CPAP machines, and they were trained virtually for about 2 hours each, coming in groups, smaller groups, on the job by a head of department of anesthetics who assist in critical care. And so we have trained so many of their nurses on elementary critical care, which they appreciate because it helps them even outside COVID-19 to be able to manage patients. I think that was the last slide. Oh yes, these are some of our achievements. We are so happy, the community support. We had people who came here to plant flowers. We have a garden for Heroes Garden, which was sponsored by RMB. We have planted flowers, beautiful there. I hope one day you will have time, because we have put a plaque and we would like to have those names remembered, just like people who go onto the war, that people in 100 years' time, they should know that these people worked at Charlotte Maxeke and they were part of this team. Continue. We have recognized staff. We have created certificates for every employee. I wish I had more money, because when I see military, they have medals, they have whatever badges. I wish I can get money, because for me, the team at Charlotte is awesome. They have done so much. The best I can do is to give them certificate that even their children will know that they were here when COVID was taking place. Go to the next. We had innovation, as you can see. We are doing some of the CPAP. Dr. Smith, the one who's carrying something, he's the one who actually did most of the innovation of this new equipment. And here we were at Denel, trying to build a South African ventilator. And as you can see, even during COVID, we had a breakthrough through cardiology firsts that were done with private sector to assist us to bring those services to Charlotte. Go to the next. Yes, and then we had a renovation in Ward 567, as you can see, where we managed to create 29 critical care beds from the 15 that we used to have. So we have this 29 plus another ward that is there. Here is another one that was renovated by a family, and it is a 20-bedded ICU. What is important about this one is that we will be able to bring trauma and neurosurgery in one unit and maximize the staff that we have in post-COVID. But the first one will also assist us to also improve on our cardiothoracic and other complicated surgeries that we have to do. Go on, I think that, yeah, those are the last ones. Yeah, thank you.
Thank you very much, CEO. I don't know if colleagues want to add, Dr. Mudora?
No, I think CEO's covered it. I'll take, maybe afterwards, CEO, if there's particular questions about particular things.
Okay. Minister, I think what the CEO maybe forgot to mention is that we are also admitting patients from private hospitals,
yes.
because they are experiencing pressure more than us. So I have then taken that decision that we'll repurpose Foloteng and make sure that as and when there's a need to admit from private, we can be able to accommodate them there. And maybe as well, the minister, the CEO did not mention that at this point in time, we are coping. We don't run short of beds in the entire province. We have made additional, from the first wave of additional, now we're sitting at 4,000 plus beds that were created. And we still have capacity at SLN that we decommissioned Telkom and Eskom. So for us to repurpose that, if we can reach a peak, it will take us 48 hours to do that. Thank you very much, Minister. Maybe I don't know if you want to add.
Maybe let me add to that. At Charlotte Maxeke, we had said if it means the whole of medical block becomes COVID, that's what we do. So we commission a ward as and when there's a need. So those beds that were shown there, it's the ones that are active. But in the event there is a need tonight at 1 a.m., we have had wards opened at that time and mobilized the staff. And maybe if Dr. Punasi can just explain how they have done it in terms of that. Yeah.
For the past 2 weeks, every 5 to 7 days, as the need has increased. As and when required. As we have our capacity increasing at Charlotte, we then commission the next one. And that's how we've been going. We've also redeployed staff from other areas within the hospital that are not as busy, for example, surgery or anesthesia or theatre, based on the measures we put in place to ensure that we have staffing for these different areas where we are now creating those space. So the plan or the research plan for the hospital has been placed on repurposing and redeployment of staff to make sure that we can meet the demand that's there, not just at Charlotte, but also within our cluster hospitals. We have communication that's ongoing. So if one of the hospitals is under pressure for some reason, we can engage amongst clinical departments to have patients transferred from one hospital to another hospital based on the acuity of the patient and what the patient requires.
Thank you.
Thank you very much. Minister, it looks like there's no additions. I don't know if the Minister wants to ask questions.
Yes, thank you very much for the presentation, MC and Mrs. Bokoshi. Just to get a sense on your observation ward, how long do your patients spend there? What's your turnaround time for your tests?
Okay. Prof. Mutara, can you assist?
Minister, sorry. So for our emergency unit in 161, where there's a ward that we repurposed, patients would come in either with an ambulance or walk in, or get referred from another institution, whether private or cluster hospital. We have been very lucky to have been given a rapid antigen test. So within 15 minutes we know whether the patient is confirmed positive or not, do a workup, and within 2 hours we can move a patient on. And because we've got that ongoing communication between the departments, with internal medicine, with the matrons, with the bed status, we have a COVID WhatsApp group within the hospital, and 4 times a day we'll get posted a bed status, which then allows us to move patients appropriately. So the one lot of patients that take a little bit longer would probably be our ICU patients, because obviously the preparation in the ICU takes a little bit longer, and there's also a limited capacity, as you're aware, of ICU beds. So it's deciding whether patients are appropriate in terms of all the criteria we have to meet those criteria to go into ICU. But generally the patients move quite quickly at the moment.
Okay. And so your average duration of stay in the hospital, in the non-general ward and in the ICU?
So ICU, I think Prof. Moore and them are looking at an average of The wards, we're looking up to about 10 days plus. The normal patients who are COVID negative obviously come in, get whatever treatment they need, and then get discharged. But the COVID patients that we have are definitely, turnaround is not as rapid as we would like it to be, because the patients are sicker. They're waiting a lot longer to come into hospital. So when they get to us, they're already at a point where they're critical and they need quite an extensive intervention to be improved.
So in your case, you are dealing with the 10-day.
At least,
Minister.
Minister.
Yes, symptomatic under treatment. And what happens to those asymptomatic recover? You have a step-down facility.
We use NESREC.
NESREC.
Yes, so the ones that, so say the last 2 or 3 days of their treatment that they actually with us, where they need minimal oxygen, and we're just trying to make sure that we can wean them. Those are the kinds of patients that we would step down then to NESREC or to one of our cluster hospitals to try and, because they obviously, as CEO was saying, their nursing capacity is not ICU trained nurses or an advanced medical nature. So they can't manage the CPAPs and the high flow nasal oxygen patients. So we still step down those patients to them.
And any record of relapses on the step down?
We have an open communication so that if there is a problem, so for example, NESREC can send directly back to us. And it's not necessarily only our patients that we send to them. So any patient that was stepped down from any of our hospitals at NESREC, if they deteriorate, will come back to us. We actually haven't had, in the last 3 weeks, we haven't had any comebacks that I'm aware of. So even the other cluster hospitals, if they have patients that are deteriorating, we're trying to work a swap system where we'll take your sick patient, you take our stable patient, just so that we have the capacity to do that.
And have you come across any recorded reinfection?
We don't have any that, I think maybe one, and we're not even sure if that was a reinfection or if the original result was a false positive. So we don't have any on record that shows that there's a reinfection.
And what's your sense of the current versus the previous surge? The conduct of the patient clinical manifestations?
Patients are sicker, a lot sicker, and they're also younger. The first wave we had were patients, older, lots of comorbidities, and they weren't as critically ill on presentation as this wave is. And I'm not sure if that's just the nature of the virus and the variant that we're dealing with, or if it's that patients are just waiting longer to get to hospital. The sort of social media messages that the hospital's full and there's no beds and you won't get treated and you might have to lie on the floor and all those sorts of things. And I think those messages out there are preventing people to actually come to the hospital sooner. And that's what we want, when people start getting sick, rather have the assessment so that you can be treated appropriately. At the moment we really are, we admitted a 70-year-old lady this morning who's been sick at home for 2 weeks, and her family have been trying to nurse her and got her home oxygen concentrator, and she's now gotten to us and she's critical. And sometimes the chances of reversing that are so much more difficult. That is the challenge.
And you do interleukin 6 tests?
Yes.
You don't have any challenges?
Our NHLS lab have been doing them. Sometimes there's a little bit of a delay, but we've been doing them as part of our routine workup of the patients.
So you don't have any challenges?
So we've been running them at the lab. Last week they told us that there may be a bit of a shortage of the reagents and that they were sending the test to private. But up until last week, we had no issues with it. So I think this week's been better. I don't know if they sorted. We haven't heard anything back from him, but I don't know if they sorted it out. But last week there was a challenge in terms of them not being able to process. They didn't have some of the reagents or something.
Okay, so but it does not pose any limitation on your approach to treatment?
So we're still managing the patient because we're managing a clinical patient. So we're not treating a blood result. Remember the interleukin and the other markers, the CRPs and all that, are to help guide us in terms of are we improving, are we deteriorating.
Sure.
So it's more a marker of activity than
What to expect? Is it going to be worse or less?
Yes. So you know, if we don't have it, yes, it's nice to have, but if we don't have it, we can still treat the patient.
Yeah. But up to now, you've been able to deal with it until this issue just now?
Yes, yes.
Okay.
Perhaps maybe the advantage, we have a direct line to the NHS.
Why did you not take a seat?
No, I'm fine. Absolutely. Absolutely. Thank you, Minister.
I'm going to just offer him a seat.
No, I'm absolutely fine. Thank you, Minister. Thanks.
We have a direct line with NHS website, and anytime Mr. Mutli's phone is on, and he's able to resolve our problem anytime in terms of even our cluster hospitals. And when we have our cluster hospitals, we invite the NHLS so that they can pick up, because we may not have a problem at Charlotte, but Carltonville, which is very, very far, may be having challenges. And what the last time, in fact, they resolved most of the problems that the peripheral hospitals had, because remember, some of their specimens have to come to us or maybe to another hospital.
Now, I was just going to say, so a few weeks ago, Southend at about 11 o'clock at night, the matron phoned to say we don't have swabs. And we arranged for them, someone, the driver came and spoke to the lab, we got them, they came and collected a box and we were able to go. So it's just that kind of the WhatsApp groups have been a huge help. Because, quickly, within our hospital, we have a COVID-19 Charlotte group. And NHLS, the nurses, the matrons, the clinicians, the porters, logistics, everyone has a representative. So if we're having a problem with security, you can put it on there quickly. Within 5 minutes, someone will respond and say it's sorted. So that has made, in terms of a lesson learned, for quick communication, rather than trying to phone someone and, get 10 different people. You can talk to everybody in one message.
So
the
shortage of beds was more in the social media than this was in the hospital.
So up until now, Minister, honestly, even with the first wave, we haven't had a shortage of physical beds. Functional beds is a different challenge. So, if we're saying functional bed, it's a warm body nurse, doctor, the bed, and all the equipment that goes with it. But we've been lucky so far. We've been able to repurpose, as Dr. Masi was saying, take from wards. So we need an oxygen base, so we're not using it in the surgery ward. Let's take it and put it into a COVID ward. The HOD and MEC have approved for us to take some of the equipment that's at Carltonville. It was actually going to be delivered today or tomorrow for us to add additional physical beds into our hospital. So, it's that kind of thinking out of the box to make a plan that we've been able to do well. And the advantage we had here is that every single department has come to the party. So the surgeons are not managing COVID per se, but they contributed nurses and doctors to help in the areas that are the same with the neonates. They're not treating COVID, but they're going to help in critical care areas. So the social workers, the speech therapists, the physiotherapists, they are all involved. Some of them are being used as porters to help push patients. So that kind of commitment to help, and everybody, as the CEO says, she will stand and screen patients in the morning if she has to. So that makes the difference.
And so, in the past few days, would you say the numbers have kind of receded a bit?
Yes, definitely. In the last week, it looks like it's stabilizing. We're still busy. We're still getting really sick patients, but the numbers do seem to be settling a little bit. I think the lockdown has helped. And definitely the trauma with the alcohol ban has been the best news for all of us.
That was only my last question. So we're now going to face TV when you say so?
I can say it honestly out there.
Pull your mask out and talk about alcohol. That's the message to get, because people must never misunderstand. It's about health workers. That's what it's about.
It's about capacity.
It's about capacity. It's about pressure that you feel. It's about being able to deal with it. Just take your mask and show them. This one.
Just close to the mic, please.
Just have a seat. You'll say that, that's all.
Thank you.
I'll stand here.
Also, I'm really being put on the spot.
It's important that people must know that the impact really of that adjusted level lockdown, it really impacted positively on the summer. Because now we can make our focus now on COVID instead of divided attention and splitting your resources.
We just want it to be said by someone else now.
Not us.
So talking from someone on the ground who works in an emergency department, in the 30 years that I've worked for the Department of Health, this is the first New Year's, Christmas period that we had no trauma. And because the surge with COVID was happening simultaneously with that period, it enabled us to redirect resources, and by resources I'm talking about warm bodies, both doctors and nurses, to be able to treat those patients who really needed the treatment. And the second thing is that it created bed capacity, because normally over this period of time our emergency departments are overrun with trauma patients. There are people sitting on the floor and on chairs. I'm sure you've all seen the picture of Barra's emergency unit, which for the first time, I think in 50 years, had no trauma during the festive season.
Bara tweeted about it, you did.
Why didn't you? We were busy treating the COVID patients. So, I guess if you're looking at it from a public point of view, there's, people feel we're depriving them of their enjoyment and it's their right to have things. But when it comes to health and providing effective health, if you think of the gunshots and the stabbings and the accidents and the taxi accidents that happen as a result of alcohol consumption, then just not having that to deal with for that period of time has been, for us, phenomenal. So it really has, the ministers and the MEC are not exaggerating it, it really has made a difference. We've had we actually now have extra ICU capacity in our trauma ICUs, where potentially we can put a medical COVID sick, one of your family members maybe, who needs to be treated, because there isn't a stabbed heart or a stabbed chest patient line. So it really has made a difference.
Minister, I want to add. Yes. Yeah. MC, on the 31st of January, I've been in health also from 1986. The first time, I worked here for 8 years and I came back and I've been here for 7 years. For the first time, for 24 hours, we did not have a single damage. People who came in was somebody who slept on the carpet or something like that. Our nurses and doctors went to the helipad for the very first time to celebrate New Year. They were outside. People don't realize how intense trauma is. We run 2 theaters 24/7. But even with the 2 theaters, we are unable to do all the trauma. As Prof. Mutara says, on Monday when we come in, matrons and clinical managers are pulling their heads out, because sometimes we have about 8 trauma patients waiting to go to theater. And when they leave theater, they need ICU. A lot of them do not have families, so they are unknown.
If they die, we have to bury them. Or we have to keep them in hospital as social people because they don't have anywhere to go. They are better, but there is nobody who can actually come and claim them. So the social workers are constantly on the case of trying to find them. At some point, we even take out our own money because they will say, I know I stay in whatever place, we can't find those people. We give somebody to take them. So social workers now are able to focus on the staff. That's why they are able to assist with the silent social problem. The occupational therapists are now assisting us with the rate of casualties, because when they come, they are so sick. Some of them, they've got gunshots all over the place. But I want to mention the most important. People who are drunk abuse our health workers. We actually have police vans standing in casualty just so that they can protect the staff. Many a times I have to be with the brigadier from Hillbrook because when they fight outside, they want to finish each other in casualty. And in fact, the day before the president announced just that, we actually had police coming here because they were watching, I don't know which match, and one of them stabbed somebody, the person died, they followed him and they wanted to finish him. So the trauma that our health workers get with alcohol, it's not okay. Health workers work very hard, especially in the public sector. And the last thing they need is to be terrorized by the very same patients that they have to treat. And I have never, since we had this surge, this lockdown, not even one person who said, I was abused by so-and-so, or I was abused by so-and-so, or whatever, because there is no alcohol.
Let me do my first comments and then I'll take the questions. Okay. Now, firstly, I was sorted. Looks like you're continuing to look at the question. No, thank you very much. Prof, thank you very much to the CEO, and thanks SABC and the whole team, the whole health team who are here. Thank you very much, and those who are not here. We basically came here to just understand what the situation is, how things are going, but also we just came to thank the staff. Thank you all for all the good work that you are doing, for the caring for all our people. We think it's important that you must know that we appreciate it and we want you to keep up the good work. That's the main reason why we come visiting, because we know you are the ones who are bearing the brunt of the pandemic. You are the ones who have who make the difference between someone infected and then recovering and getting back to join their families. So we take this very, very seriously, and we want you to know, and to all the members of your team, and to the health workers in general, we want to express our sincerest gratitude for the work that they've done. We do understand as well that the health workers are doing this at a great sacrifice to themselves. Firstly, the risk of contracting the infection is something that is very serious, but like loyal, dedicated soldiers, they go to battle to defeat this invisible enemy and save the lives and save our nation and come back, even though they could themselves also suffer the consequences thereof. What has been good in the past few months has been the fact that we're all together on the discussions in relation to the provision of PPEs. We have visited Steve Biko Hospital. We actually went to engage the chairman and the secretary of the union to ask them about PPEs. And they said, no, they have a way now of dealing with it. And this is our understanding, because we have put up what we call occupational health and safety committees. We have opened up for management at facility level to discuss the issues of the shortages of PPEs in such a way that we have said that if there's no PPEs, there's no work. And we actually thank the unions because they raised this issue. And there was always a challenge in terms of understanding between us as to what the problem was. Because there's a big difference between the shortage of PPE at the coalface, at the ward, at the facility, and having a full stock in the provincial warehouse. There's a huge difference there. And so we're no longer discussing whether you've ordered enough stock and it's kept somewhere in the warehouse. We want to know if the PPEs are available to those who need to use them. And we've actually seen that of late it's not coming up as an issue. And therefore we've said the staff members, the health workers, the unions, whenever there's a problem of PPEs, raise it. And it needs to be raised at all levels up to the point that in fact it must be raised with the minister if necessary, and we'll act on it, because the understanding has to be the fundamental fight against COVID-19 at the point of the health services is going to be a fight led by health workers who are prepared psychologically to fight the COVID-19, and that they are well protected, but also they are well trained. And this is important, because I've seen here in your presentation you're talking about training people and so on. It's actually part of the most important armament to deal with this COVID-19. You can't deal with an enemy that you fear. No soldier goes to battle, they fear the adversary. In this case, we had a lot of that at the beginning of the COVID-19. Right now, we no longer have any fear. The level of confidence amongst our health workers, the level of experience in dealing with COVID-19 now, to the extent that in some of the provinces, it took a long time for people to feel the pressure, even though they were now admitting patients almost twice as many as what we've seen in the previous surge. So I want to say thank you therefore to the team and health workers. And that's really the first reason. That's the first reason for us visiting the institutions. We went to visit KwaZulu-Natal yesterday, and tomorrow we're going to be visiting Limpopo, because these are the areas where we're seeing a lot of pressure. We did visit Western Cape a while back and Eastern Cape, and so we want to be able to see what else needs to be done for you to be able to respond. Now, as I have been listening, I have been impressed with the fact that you are sticking to a very strict protocol of managing the COVID-19, and I've seen the level. In fact, even more impressed with the kind of ops room that you're running to look at how the flow of patients and all the challenges that have to be dealt with. I've also been impressed to see the level of participation by all different levels, including management, onto solving the problems that are coming on the ground. It is for me very, very important that from the first COVID patient, and I recall that very well because I was in Pietermaritzburg to deal with the crisis in a school when the first patient was reported. And of course the next patient was reported in Gauteng. That's when we realized that there was a whole team of friends that actually had been together in Italy at that point. That's now history. It's a kind of history that's so far behind us that is now almost out of our memory. You know, Professor Mutalo, we went to Polokwane, and there was a lot of fear when we were going to receive people who were not infected. They had no COVID infection, and But everyone was so nervous about COVID-19. So that, I think, is just part of the history that we've been through as we move. I'm also quite, I've been listening, and one of the issues I've been concerned with is the whole issue of staffing, because every now and again we come across this problem. And so I think it's important that we do everything to employ additional staff. Yes, contract posts, last time we were to do that, and at some point, in fact, some of the staff was actually employed by head office. Directly were to just go and contract staff and bring them into hospital. And a few hospital managers woke up and found there were nurses who said, we've been sent to come and work. And some of them said, we don't know you. And we said, yes, you don't know them, but they are here to help you. So that's the issue. I think it's important because of the other issue that you raised. The problem of exhaustion is real. And the problem of exhaustion has actually hit us more because to be honest, this surge came much faster than we anticipated, and it became worse than we actually initially expected. And this partly has also got to do with the degree of complacency at the level of society, when we start dropping the mask, start going to big parties, and so on. Part of the reason why we're seeing more young people coming in is also because of the behavior when younger people kind of got into activities that were super spreader activities. So those are some of the things that we have looked at as we're talking now. Now we've also seen that there is a new variant which is tending to be more highly transmissible than the previous variant, and therefore that means that at any one time more people are infected than before. It doesn't mean that it makes the disease more severe, but if you've got a group of people who are infected and they are more in number, many more people will be more severe because of the large numbers, not necessarily because the virus has inflicted worse manifestation into the individual. So that we need to always clarify, because it's important for us to understand that to contain this virus, we need to do exactly what we did before so that we can actually reduce the impact. So that way, the numbers of people who are infected will be fewer, the number of people who have severe infection will be fewer with the variant in present. So we mustn't sit and think that this variant is going to make, we've got no way of dealing with it. If we were strict on the masks and distancing and use of sanitizers, we would actually defeat the same variant in the way we defeated the first wave. And so that message needs to come very strongly. And it's important to make that message very strong, because the exhaustion comes from too many people getting positive, getting sick, getting admitted, getting very severe, and needing more and more attention, because everything happened at the same time with too many people getting infected at the same time. So we do anticipate that there is a problem of exhaustion. We also do understand as well that you have to do your best to try and create space for rest, for shifting people around so that they can find a way to cope. We have to defeat this surge as well. We need to see it over. We need to see of normalization in the way we run the health services. A number of facilities have had to delay the elective surgery and some of the chronic treatment and some of the preventative work, family planning, immunizations. They tend to be affected because of all of this. So we need to understand, therefore, when we ask people to be very strict with the use of masks and sanitizers and so on, we're doing that because ultimately it's got a knock-on effect on other ailments, and therefore we end up someone else who's going to succumb onto something that we could have treated simply because we had everyone now focusing on COVID-19. The other diseases still cause a lot of illness. The other diseases cause a lot of death. So we can't just let go and say we're just going to focus on COVID-19. So that, for me, is an issue. We have to accept that the issue of exhaustion is a very, very important issue for us. And so it does impact on the size of staff, the numbers of people who are available, and so on. Experienced and as confident as our members are at this point. And that's why I think it's important to raise this issue. Then, of course, we have seen that with the new experience, there's an early intervention in the use of oxygen that saved a lot of people. Now, that way, we've started to find that there's a lot of pressure on the utilization of oxygen, and we went to Steve Biko, we looked around and we saw a lot of cylinders which are being brought in every now and again. Even the oxygen manufacturing plants are under a lot of pressure, but we need oxygen. We need oxygen in all the hospitals. We need the oxygen at casualty, at the outpatients. We need oxygen in district hospitals. We need oxygen everywhere. And we're trying to do our very best to make sure that that oxygen is available, because that's what saves lives. And all of us with the experience, we now know that's what you do. High-flown, oxygen, or you use it ahead of even having to. We use it ahead of having to put people into the ICU. There are many people who actually, turn away from ICU because they were given adequate, attention with oxygen. It taxes a lot from the individual to care. When you've got people who are under such severe situation and you are also under your own pressure, anxiety, it's even more, exhausting. So that issue it's an important issue. So we've noted, therefore, all your efforts towards psychosocial support, even at work, even to give them space to move out into their homes. And we must understand that when someone gets off from work, they are now going into a full-time responsibility as a family member, as a parent, as a father, as a mother, as a carer of the members of the family. And when you get there are new problems that we have to face, and therefore it's always very important that we must understand that we can't sustain continuous exhaustion of our members. So we thank you for all the work you do, the psychological counseling that you do, and I think that all the hospitals have tried to now find a space to be able to deal with this particular issue. This issue of certificates for staff and writing the names, I think is also very, very good. At this point, we have got over 51,000 health workers who have actually tested positive, and probably just under 600 that who have lost their lives. We really, feel very sad about this, and we always want to convey our condolences to the parents, to the friends, to the colleagues, to everyone who has lost their loved ones during this difficult time. Of course, it's always an issue because we have seen that the numbers of people who are positive gets higher amongst health workers who are in the community where the positivity rate is in any case high, because we meet as part of the community. When you're in the community, you are not wearing a PPE. You therefore get exposed, and so that becomes some of the challenges. Something that has happened this time around, excuse me, is the filling of the private hospitals ahead of the public hospital. Now, this issue we're still trying to understand how does it happen, because in the previous surge, we had an earlier attention focused on the private hospitals, but soon thereafter the public hospitals took over. So I've been very uncertain as to what this means in terms of the movement of this pandemic. But at this point, we've actually had to get patients referred from private sector to public hospital, whereas before we had made an agreement to actually refer all our patients to the private hospital, in particular to the ICUs. So there's something here which we have to start and analyze and see what would have happened in this case. We saw this first time in the Eastern Cape. In the Eastern Cape, private hospitals were full. We actually ended up with patients with medical aids going to be treated in the hospital which was put up, the field hospital put up by VW in the Eastern Cape, and therefore we realized that we need to collaborate between public and private. Doesn't matter where the person lands. They must actually find that this system does not create fault lines where people can fall into cracks simply because your private hospital is unable to take you. It doesn't mean that you must now suffer. You need to then find a way of being treated in the other hospital. But I must also say that the reputation also of this hospital has been quite good in terms of treatment. Outside this, we actually follow a number of patients that we become aware of, and him in the middle of the night, sending him text messages, and he would come back. The amount of dedication that we have seen is actually unbelievable. So we do want to say thank you for all of that. So you are now watching the movement and the numbers of patients, and therefore you are able to open up beds ahead of the surge. That's the way. What we found even in the previous surge. You can make all the plans about COVID-19. Wait until it happens. That's when the plans are going to be actually happening, because you only know then what is the impact, what's the number. In Steve Biko Hospital, the CEO was saying, everything was quiet and everybody was fine. And on one Saturday, 3 patients came in, and the following day there were 19 patients. After that, it was like a storm. So you can only plan for COVID-19 by being ready to move speedily, to actually act and shift and make sure things are able to accommodate your rising flow of patients. So from that point of view, I am very pleased to hear, Prof. Because that's the issue that I wanted us to deal with, and that's the issue of the observation wards. That's what tends to create an impression that the hospital is full. If you get a bottleneck there, then people feel that, particularly the ambulance services, then they start panicking to say they can't put a patient in because the hospital is full. When in fact the wards are open, but the triage system is such that the observation wards are delaying the movement of people. Now you've got the question, because I asked the question and I knew you knew where I was going to as well, because the real issue is that we've introduced antigen test, which is a rapid test. So what that does, it allows you within 15 minutes to be able to determine whether the person is positive or not. And for those who are positive, they can move on quickly, no problem. You might then wait to recheck the ones who are negative, but it actually opens up your wards. And I'm glad that your system is actually allowing that and is flowing properly. So that, for me, is an issue. So we have to keep watching the numbers. MEC, the 4,000 beds, we're expecting, for example, that when there's pressure, excuse me, the NASREC must be able to take those convalescent patients in so that it can open up space for intensive treatment for those who need to be taken into the main hospitals. Now that way the system is working well, because then all you do is that this one is not ready to go home but doesn't need so much care, but we need the bed, move them to NASREC and so on. Then when you do so, the field hospitals are doing what they were meant for. Then after a few days they'll be discharged, but what it means therefore that we can always deal with the flux of the patients that are coming in beforehand. So that for me is important. The challenges about the period of stay in hospital, if we have the numbers increasing, that's when we start getting a lot of problems, because if you've got too many people who are sick, the percentage of those who are severe will be higher, and therefore those will spend longer in the ICU, and that's more, it costs more in terms of human resources, in terms of treatment, in terms of all the equipment and so on. So we keep watching now as to what else needs to be done to actually make sure that we improve. At least the presence, the introduction of dexamethasone was quite helpful to reduce the level of the mortality at that level. But when someone gets to the ICU, it's not easy. It's usually very, very difficult, because those individuals tend to have a much more severe situation that requires a lot of support. So we do want to say to our people, we know it's difficult that you've got someone who comes to hospital and they cannot be visited. Because for us, even if you're sick, if your relatives come and visit you, it then becomes easier for you to bear the pain because you got the support. Now, once you go into the hospital and you don't get that support from your family, sometimes you can't even phone. I had a friend who was in hospital, and I spoke to him, and I could realize that he was having a difficulty with breathing. The consultant who came in after that called me and said, no, we took your friend's cell phone away. We told him that part of the treatment is stop talking on the phone because of the pressure. In other words, now the connection with the families and friends is actually interrupted by the treatment. We understand that. It's very, very difficult, we understand that. But even the question of people coming in to visit, people who are in the ward, is very difficult. For a nurse, for a doctor, for anyone who cares for those, has to go through quite a process to get themselves into the PPEs and change from the dirty area to a clean area and reverse and so on until they are able to get out of the hospital knowing that they haven't spread the infection. Imagine now for the 200 patients that you've got, each one with one visitor, it means you'll have to change PPEs 200 times. If you've got 3 visiting hours per day, it's going to be 3 times of that amount. Now, it could have been easier if you just put on a PPE. But if you make a mistake and you then end up breaking the cycle of infection control, you now are going to take the infection from me and go home. Many people who have not been trained would actually put us into that problem. So we do want our people to understand that it is very difficult, but that's the only way we can manage this situation. And then, of course, it takes me then to the one issue, and that is, if we look at the trends, for the past few days, we went as high as recording over 20,000 people were positive per day. Those numbers have started receding a little bit. We believe that that is an indication of effective use of masks, of sanitizers, of distancing. That's what is actually making that impact. So we would like people to continue to do what they've just been doing well. Because as a result of that, we're waiting to see how Gauteng is going to cope. Gauteng last time went up to about 3 times higher than the peak that was in KwaZulu-Natal, maybe 2.5 times, and even more than what happened in Cape Town, in Western Cape, and more than what happened in Eastern Cape. Okay. This time around, we've seen slightly different trends. In the Western Cape, the surge started early, but instead of that surge, it was almost to the same peak with the previous one, except it's lasted much longer. So even though the numbers were no longer increasing in the Eastern Cape, you couldn't feel that there's a difference in the numbers simply because it was continuing at a high level plateau. It's now kind of coming down. But you'll also understand that when that happens, the level of illnesses drags a bit longer because people will be sick even if there are fewer. So it will drag longer for another 2 weeks or so, depending on how severe, so it drags a bit long. And therefore the deaths also do the same. Then the Western Cape surged to a level which is almost twice the size that it was in the first surge. And then at some point we had very optimistically the Eastern Cape team were saying, well, they think they are now coming down. But actually what happened was a plateau at that peak. So the plateau at a peak was still a peak, and therefore it's actually taken quite a while. In the past few days it's shown a trend downwards, which is very promising. Mm-hmm. So now in KwaZulu-Natal went almost higher than where Gauteng was during the peak, which was quite unexpected. But at the same time, we've seen this now in the past few days, there's a slight decline. And that decline, we believe that it was going to be because of a movement of people, the migration of people away from the holidays, and that the peak was also occasioned by the fact that a lot of people actually tend to use the coastal provinces to visit. Eastern Cape was saved by the fact that the lockdown came a bit earlier, and therefore there was quite a lot of restriction in terms of the spread of the infection. Now Gauteng started showing a slight trend downwards. We're holding our fingers crossed because in the first instance, it's still too soon to know what is the impact of the people who come from all over, particularly the coastal provinces which had a high level of infection. Now, what then happens to them when they come back to Gauteng? And some of them have gone to Limpopo. We've seen Limpopo has already shot higher than the previous peak, the previous surge. So they will be all coming back now to Gauteng. So we are waiting to see what the impact is going to be. For another week or so, if we keep the trend, that means we might be slowly getting out of the surge. But if the impact of those who are infected was still incubating, then of course we're still within that time when those numbers can still show up. So if we didn't institute the level 3 modified approach in terms of restrictions, we would have been worse off. And I think it's important for all of us to understand that we have been saved because of the very strong restrictions that we have all had to endure in the process. But lastly, I can never say it better than how Prof and the CEO have said it. Alcohol, irresponsible consumption of alcohol tends to create unnecessary and avoidable accidents. In the case of this suspension of the sale of alcohol, literally all the major hospitals have got the same response. They have seen huge reduction in the acute trauma, in emergencies, in interpersonal violence, stab wounds, gunshot wounds, motor vehicle accidents, large taxi accidents where you've got a number of people killed at the same time, and so on. That actually has helped in the fight against COVID-19. And that means, therefore, that we have been able this time around to assist and support our health workers. It is most frustrating and actually disheartening when you've got people who are sick, and then you've got people who are not only avoidable in the causation of their accident, but they're also, some of them, abusive. And this is what we have actually had. Abusive. The pressure on our health workers is so severe that this time around it had to be done. And we are saying we are still very high. So no one must now suggest that, well, if you think that the numbers are going down, why don't you reduce? We're actually, unfortunately, a peak too high. So even the reduction has not even reached the peak which we were in July. So we're still very far up. So it doesn't mean that even though we think the trends are coming down, we have actually come to a point where we say, okay, take off your mask and you can stop this. We're not anywhere near that. We're simply just saying we have to encourage society, all South Africans, that what you are doing now is making an impact. Please keep that up. What we are also saying, when we said, people, please give us a sacrifice, no alcohol for a while, that has actually saved our health workers and have actually opened up space for us to treat quite a ravaging pandemic, which has gone into many hospitals 2 times, 3 times, or even 4 times higher than what we're seeing before. So that is really what has been, for us, a very important message for the day. So I'd like to leave it at that for now, and I'm sure that we have answered all your questions, and therefore, thank you. So we want to give to MEC.
All right, that was Health Minister Dr Zweli Mkhize briefing the media following a walkabout at the Charlotte Maxeke Hospital. We've been following that, and of course some things to come out there, not very different to what he's been saying of late, but talking about private hospitals being full. So some private hospital or medical aid members have had to go to public hospitals, and really this enforces the need for coordination between private and public hospitals. He is saying that that's a trend that is being seen amidst the second wave. And also just it's a numbers game. With the new variant, more people are landing up in hospital, but he's saying it's not more deadly necessarily. We've heard this from scientists, but because more people are getting infected, a percentage of those, a higher amount of people are landing up with serious illness in hospital. And of course, paying tribute again to